So in last week, we learned about antithrombotic drugs. Antithrombotic drugs. Under that, we classified, what is that? We classified anticoagulants. We studied that. Anticoagulants, heparin, warfarin, sodium. We studied that. Now, we also studied fibrinolytic or thrombolytics. Thrombolytics. So we also studied them. So thrombolytics, you see in this picture, you see this is the thrombus or clot. What happens if it dislocates, then it is called as embolism. And if the blood vessel is big, there is no issue. If it goes to the smaller blood vessels, then what happens, you see, in this diagram, you see, the blood can pass, can flow from the thrombus, It is flowing, you see. If it dislocates and if it comes to the fine capillaries, for example, aorta, coronary artery. So in this diagram, we have seen in that diagrams, in angina pectoris, the main arteries becomes fine, ascending coronary artery, descending. So what happens? So it becomes very fine. Then if this clot goes to the fine blood vessels, what happens is that the circulation is stopped. Then the issue starts. This is where these drugs will play very important role. Anticoagulants will prevent clots, both in venous and arterial system. These are new things which we didn't study last. Fibrinolytics or thrombolytics dissolve the clots or embolus that causes serious and life-threatening damage. Streptokinase, urokinase, that which we studied, plasminogen activators. They dissolve this clot already formed. This will prevent formation of clot. Whereas these drugs dissolve these clots. So when you are giving these drugs, fibrinolytics, we studied last time, it will be given in the form of injections. You need to stay in hospitals. If there is any complications, they can observe. Then coming to these antiplatelets. Antiplatelets are effective in arterial circulation, even in thrombosis. So where anticoagulants have little effect, these are also very good drugs. People might have learned during bleeding conditions, the platelets will aggregate. The platelet aggregate and stops bleeding. But here, what happens during the process, there is overactivation of some of the receptors present on the platelets and causes aggregation, even there is no any hemorrhage, even if there is no hemorrhage. So when platelets aggregates, so suppose if there is a damage here, suppose if there is a damage here, if the blood vessel is damaged here, if there is a cut, what happens? Platelet needs to come here and get adhered one by one to each and stops the bleeding. But because of overactivation of some of the receptors, the platelets will come just like a clot. So that's why platelets also, antiplatelet drugs also help in our cardiovascular diseases like deep vein thrombosis, coronary artery, angina pectoris, coronary artery syndrome. In all these conditions will help. So the patient will be given antiplatelet, for example, aspirin or dipyridamole, some of the important drugs, or clopidogrel. So they're having combination of drugs, clopidogrel and all those, which are antiplatelet drugs. So what I told, in some of the patients, no, the platelets are overactive and they get clot. They get coagulation. They get a coagulation, and if that blocks minor blood vessels, then the issue comes in. Then the issue comes here. That's how these antiplatelet drugs will act. This is primary prevention, whereas these are secondary prevention drugs. Prevention drugs. So nowadays, both of them, combination of these two drugs are available. Or I don't think so. Oh, in these drugs only, antiplatelet, there are very good combination of drugs. We will discuss. They are widely used drugs. Here you can take acetrom, warfarin sodium, depending upon our condition, dabagatron, direct thrombin inhibitor. Generally, patient, if it is an emergency condition, they give parenteral route of anticoagulants. If it is after treatment, then they go for oral route of administration drugs, warfarin sodium, acetrom, those drugs, dabagatron, oral route anticoagulants. We classified the drugs into parenterals as well as oral anticoagulants. So that is it. Now let us go one by one. So now you can see it here. Okay. Now you see the platelets. The first topics, first 2 to 3 slides will take longer duration of act, longer duration, remaining actions, drugs very fast, and we can finish very fast. You see, the platelets will be traveling across the walls of blood vessel. They will be moving across this. Suppose if this is the blood vessel, if they generally the platelets, white blood cells, RBC, they will be circulating at the center of the circulation, whereas platelets will be traveling near to the walls, both upper and lower. So whenever there is a cut, some of the platelets will come and bind to this endothelium, See, this is the endothelium or collagen. It comes and binds. What I told, platelets will be moving near the walls. Whenever there is cut, there is some changes in our body, in the blood vessels, that is endothelium, and platelets will come and adhere. You can see it here. They get adherent. So on the platelets, there are many receptors present on it. You can see it. GP1b. GP means glycoprotein. Then glycoprotein, and also Van Willebrand factor. And also it is having, you see, thrombin receptors. These are all the receptors present on the platelets. ADP, adenosine diphosphate receptor, thromboxane, thromboxane A2 receptor. So all these receptors can get activated during hemorrhage. So the first thing what happens is that it activates GP1b, glycoprotein 1b, which is present on the receptor, and also when this is activated, it also activates Van Willebrand factor, making both both of them, when they get activated, they bind to the collagen very fast, or endothelium very fast. So Van Wilbert factor, which is present in our circulation, will stick to the collagen, and in turn it binds to the platelet. So when they bind to this, when GP1b activated, it binds to GP1b receptor, and Van Wilbert factor, when it binds, know what happens? It allows other factors, for example, thrombin. We know that prothrombin is converted to thrombin. So all that clotting activation process, whatever we studied last time, they also get activated. So thrombin, which is formed from prothrombin, will bind to its receptor. At the same time, ADP, adenosine diphosphate, will also bind to its receptor. And thromboxane, which is formed from Cox cascade reactions, cyclooxygenase, it also bind to its receptor. Making all these will make other platelets to come in contact each other. All these factors will make, you see, if there is a damage here, now what happens? Platelets are coming closer to each other. Usually they used to flow like this at the walls. So just like our security people, how they guard our walls, these platelets will guard our blood vessels. So when they bind to all this, what happens? No, the platelet which is in the circular form, will become like a what is that? Like a jellyfish, You can see it here in this diagram. I will show you next slide also. You can see that when these factors are bound together, what happens? They bind to this. See, collagen is binding to its receptor. Thrombin is also binding to its receptor. ADP will also bind to its receptor, and thromboxane also bind. So each platelet has its own receptors. What happens when bind all these factors binding? It causes, see, all the platelets which were in traveling circulation will move to the walls. And for example, now you see there is some mandamana here. Now they're telling that it will be happening in the airport. Now all the police people are moving towards airport. And so in the same way, now the platelets which are in the circulation will come and bind to this. So they bind to their receptors. So when they bind to this, the platelets which were in a circular shape has become a jellyfish type uh, uh, shape, and further activating. See, previous was GP1b, glycoprotein 1b. Now GP1b, GP2b, or it's also called as 3A, will start activating. So which is in dormant, they are in dormant stage. Now they get activated, causing cross-linking of the platelets. And so that's what we written as GP protein, glycoprotein 2B or 3A plays major role in regulation of platelet adhesion and aggregation during hemostasis. So its shape is changed. You see, its shape previously it was like this, like an egg, oval shape like it is. Now what happens? Its shape is changed and shape is changed. So once if the shape is changed, what happens? The surface area is increased and interlocking occurs. Interlocking occurs. So this is how the platelet aggregation occurs. Now, there are some drugs, you can see it cross-linking, everything occurs, fibrinogen, everything will come and cross-link and stops bleeding. Stops bleeding. This is normal process. Normal process. Whenever there is an hemorrhage, this process occurs. So because now God has created, see, if a GP1B activates and Van Wilbert factor gets activated, that is not enough. That's the signal. What we get, conformational changes, what we get after binding is not enough to call other platelets to come across. That's why all these factors, collagen, uh, thrombin, ADP, thromboxane, will start this signaling, calling these signals will cascade further platelets to come closer. So that is also not enough. After this getting activated, then the dormant GP2B or 3A will start activating. Once this is start activated, what happens? It will be proliferating. So all the platelets will come and cross-link and fibrinogen. Thrombin, prothrombin will convert to thrombin. Thrombin, what it will do? It converts fibrinogen to fibrin, causing cross-linking. This is the normal. You can see now adhesion, activation. Then what happens is aggregation, and finally there is stoppage of bleeding. But in a cardiovascular disease person, what happens? This GP2B and 3A will activate by themselves and causing the platelet aggregation enormously. So our drugs, you can see it, you can see the drugs. See, they are blocking COX inhibitors. When they're blocking COX, cyclooxygenase, what happens is that it blocks the activity. It blocks the activity of what is that? This factor. There are some drugs which block ADP receptor or ADP formation. ADP formation drugs. Now, our anticoagulants will act on thrombin. There are some drugs, direct thrombin inhibitors. So this is how our drugs. So there are some drugs. Which. So here what we learned, GP2B or 3A is very important role. You see, glycoprotein 2B, 3A plays a major role in regulation of platelet adhesion and aggregation during hemostasis. Drugs which block this block. So what are the drugs? COX inhibitors. You can see the classification of drugs. So COX inhibitors. Then ADP receptor. It is also called as P2Y12. The same receptor, ADP receptors, inhibitor, ADP receptor. This is COX inhibitors. This is ADP receptor or P2Y12 receptor inhibitors. Then phosphodiesterase inhibitors. What is this enzyme? It prevents formation of ADP. Phosphodiesterase inhibitors. So diestrase inhibitors. Then then last drugs, you see, these are very promising now. What is that? GP2B3A antagonists. So that is the what we are blocking. So these are the class of drugs which play very important role. We can see some of the drugs examples, you see, COX inhibitors, COX inhibitors. Example is aspirin. That is very good drug. Aspirin is very good drug. Some more drugs are there, but aspirin is still very, very promising drug. Let us see. Triflusul indobuphine. Now you can see their uses. At the same time, I have written in the classification, used widely in patient at a risk of thromboembolic diseases. What are the thromboembolic diseases? Angina pectoris, myocardial infarction, deep vein thrombosis, or even during what is that? Cabbage, coronary artery grafting. During that condition, they use aspirin at low dose. We will discuss that. Next, ADP receptors, which is also called as P2Y12, P2Y12 receptor inhibitors. They are further divided into three types. So here you can see thienopyridine. I will show you the structures and everything. Thienopyridine derivatives. There will be pyridine and thio group. What are the drugs example? Clopidogrel, very, very widely used drug, along with the aspirin and clopidogrel. Combination is present. They are anti-lipid drugs, clopidogrel, ticlopidine, prasugrel, then triazolopyridine, pyrimidine, ticagrelor, then 6-aminopurine, cangrelor. These are ADP receptor inhibitors, or P2Y12 inhibitor. Now you can also see these are beneficial in the treatment and prevention of acute coronary syndrome, angina pectoris. In that conditions they use it, and also in prevention of thromboembolic events. Then phosphodiesterase inhibitors, dipyridamole, or silostazole. These are phosphodiesterase inhibitors. Then they are used in prevention and in following stroke. And also you see dipyridamole or silostazole is usually combined with aspirin. And also WHO has suggested taking the dose of aspirin between 150 mg 150 mg to 150 mg to 300 mg at low dose for all the people who were after 40 or 45 years, because nowadays many people are getting this cardiovascular issues. They are suggested. That is only suggestion, advisory. Now you should take the doctor advice and before taking. Then last drugs, very, very good drugs. This is a activation of these two receptor causes catastrophic accumulation of what is that, platelets, so that the bleeding can stop here. Now if they block this, wide range of clotting will be stopped. Now you see abciximab, these are what is that? I'll tell. Abciximab, eptifibatide, tirofiban. These are the some of the drugs which are used here that are classified under GP2B and 3A antagonist. Now you can see they're administered intravenously, effect during percutaneous coronary intervention. They mainly used along with that, whatever the cardiovascular drugs we have used. So this isn't. So you can see it here. These are, yeah, I was telling GP2B3A inhibitors are monoclonal antibodies. Monoclonal antibody. Further classification you want, you can see it. COX inhibitor, aspirin, P2Y2 inhibitors, nothing but ADP inhibitors. You can divide into irreversible, reversible. And aspirin is also irreversible inhibitor. Thromboxane is inhibited by aspirin irreversibly. Then GP2-3B, this is monoclonal and synthetic ones. Abciximab. Then phosphodiesterase inhibitors. So dipyridamole, silastazole. So these are the some of the drugs and classification, total classification of these drugs. Now, first let us see aspirin. We are almost to end. Aspirin, this is the structure of an aspirin. We'll come to those figures again. You see, this is the structure of aspirin. Aspirin is acetyl salicylic acid. This is the acetyl group, and totally this is called as salicylic acid. There is no H here, salicylate we call. So this is acetyl group, acetyl salicylic acid. Now, this is NSAID drug. How does it act? How does it act? It blocks prostaglandin synthase. It blocks the prostaglandin synthesis. One of that is, how does it blocks is, so what it does, you see, in the receptor, COX enzyme, COX means cyclooxygenase enzyme. So this COX enzyme has important functional group which binds, which are nothing but binding site. One of that is, you see, some of the important binding site which helps to bind to the COX enzyme is tyrosine 348 and tyrosine 385 and serine 530, amino acid serine 530. These are the binding sites which bind to our salicylic acid. So now you can see it, how it binds here. When it binds, what happens? Serine is a hydroxyl containing amino acid. You see, this is the serine group. Serine is hydroxyl containing amino acid. Now, what happens is that this acetyl salicylic acid will donate this acetyl group, will donate the acetyl group. You see, this is our drug. You can see it here also. We given the structure, salicylic acid. This is the structure of salicylic acid. Now, during the process of activation, what happens is that the acetyl group is donated to the serine 530 amino acid. Remaining portion will be attached to here, this. Now, this, when acetyl group is attached, what happens is that the enzyme becomes inactive. See, enzyme is inactive by acetylation at serine 530 amino acid. So salicylic acid will come out from that enzyme. So this, when the COX is blocked, what happened? There is no further prostaglandins. One of that is very important is thromboxane. TX thromboxane A2. Thromboxane A2, it blocks it. So when thromboxane A2 blocks, what happens is that there is no platelet aggregation. You can see it in our diagram, what we studied, you see, thromboxane. So this, when it doesn't bind, thromboxane, if it doesn't bind, what happens is that aggregation, it will stop. Aggregation, it will stop. So this is how the drug acts. So what is the main function? Acetyl salicylic acid will donate acetate group to the COX enzyme and thus prevent formation of thromboxane. When thromboxane is not there, what happened? There is no platelet aggregation. This is thromboxane is very, very important, very, very important for binding. We also see in here. Thromboxane is very, very important in aggregation of platelets. And so this is how it looks, you see. It stops. So there is no further platelet aggregation. So this is this bindings, acetylation at serine 530 is irreversible. So what happens? You can see it, aspirin produces irreversible inhibition of enzyme cyclooxygenase, therefore causes irreversible inhibition of platelets. For the rest of their lifespan. Lifespan of platelets is 7 days. So for 7 days, the platelet will not get aggregated. But every day the patient will take. And also you can see it, aspirin is very good. Absorption is there, is an acidic drug. Aspirin is acidic drug. So at acidic pH, what happens is that this drug can be absorbed very well and very well it is absorbed. This is how aspirin acts. Then these are the uses used in secondary prevention of transient ischemic attack, heart attacks. Sudden ischemia means decreased blood supply. For some people, the clotting, the patient will become such a way that morning, if you see the PT-INR, it will be normal. By evening, if you check, it becomes over and clots will be there. So in that it is used. Then it's also used in ischemic stroke, myocardial infarction, then prevention of ischemic events in patients with angina pectoris, and prevention of coronary artery coronary bypass graft occlusion. So new blood vessel you created, the new blood vessel can more chance to get clot again. It prevents that. So these are the uses of aspirin. Now these drugs, you see, thienopyridines. These are what is that? ADP inhibitors, ADP receptor inhibitors, or P2Y12 inhibitors, receptor inhibitors. So these are the drugs. Drugs you can see it. This is pyridine nucleus, pyridine, and this is thiophene drugs. Both combined together, we call it as thienopyridines. These are prodrugs. they need to get activated to show action. For example, you see, the prasugrel is having an ester group, So what happens is that on hydrolysis, the ester group will go and forms a lactone, thiolactone. See, in cardiovascular drugs, digital is we learned lactone ring is present. If the sulfur is oxygen, then we call it as lactone. Now here sulfur is there. That's why we call it as thiolactone. Thiolactone. This is thiolactone. Prasugrel, thiolactone, because ester group is broken and you get keto group here, and this is called as thiolactone. So further oxidation by cytochrome 450, cytochrome 50, what happens? The lactone ring is opened. The lactone ring is opened. Now, this is the active molecule of prasugrel, which go and bind to ADP receptor and thus preventing ADP to bind to itself. The same way, thiolactone doesn't have any ester group here. It doesn't have an ester group. Now, what happens is that it gets activated because it needs to have a lactone ring. Lactone ring here. Here also you see lactone ring is formed. So thiolactone ring is formed. So further oxidation, what happens? The ring is opened, and now this is the active metabolite which binds to that ADP receptor. The same way clopidogrel, oxidation. You see, this only prasugrel is having an ester group. It's having an ester group. Remaining doesn't have any ester group. So oxidation, it causes keto group to form lactone, thiolactone. Further oxidation. Now this will go on show activity. You can see these drugs are 90% bioavailability. Usual best combination, aspirin plus clopidogrel. There are many companies are manufacturing clopidogrel plus aspirin. So this is what they do activate. Now you can see it here in this diagram. What happens is our drugs will prevent binding ADP to its receptor. When it doesn't bind, what happens is that usually let me tell the normal function. When ADP binds to its receptor, there is increased calcium, and this calcium in turn will activate GP2B3A receptors. 3A receptor. So this is, if you block this, what happens? There is no calcium, there is no activation of GP2B3A receptor. This is deadliest, I told. So all our drugs will block this on activation. So these are the uses. Same secondary prevention of ischemic complications, ischemic stroke, peripheral artery diseases like deep vein thrombosis and all those things. Then in acute coronary syndrome, angina pectoris, myocardial infarction, in that condition, we use these drugs. Then, so this is a phosphodiesterase enzyme. Phosphodiesterase enzyme, it will increase cyclic AMP levels. Cyclic AMP levels increase and inhibit uptake of adenosine in platelets. So inhibit calcium entry into the cell and decrease platelet aggregation. This is a dipyridamole, one drug. This is the drug. So what is happening is here, let me show you. So this is a one pyridine molecule, and this is also one more pyridine molecule. So that's why it is a dipyridamole. uh, pyridamole drug, which is acting by phosphodiesterase 3 enzyme. So this is it. Then it's also, you can see uses. See, enhance the action of warfarin and aspirin, decrease the incidence of thromboembolism and transient ischemic. And also this drug, one more important thing is that whenever you want to do some imaging check, that is by thallium scanning, if you give to the patient this drug, what happened? The blood flow increases, and we can see the blood flow in the heart. So this is an. Then you can also, you see, these are the uses. Then last, GP3B inhibitors. You can see in this slide all the events whatever we told. Resting platelets. It's in this diagram. Now what happens? GP2B and Van Wilbord factor will bind. Then what happens? Other clotting factor, not clotting, other factors on the other receptors on the platelets will activate. More of them is GP2A expression. Now our drugs will bind to this and prevent further interlocking. These are GP2 and 3A inhibitor, abciximab. Very good drugs in the treatment. So these are the uses. It is available. You can see it. It is a chiromeric monoclonal antibiotics. Sorry, antibody antagonist. Sorry, antibody antagonist. Then percutaneous. So humerase. These are the side effects of all these drugs is humerase, thrombocytopenia. So very dangerous drugs. So that's why we need to do in presence of a doctor. These are the drugs. So this is my class. Any doubt, please?